Bueno, 8:01. Ok, so let's go. Buenas noches, ¿cómo están todos? Muy bienvenidos a nuestro primer webinar del año 2020. Esta noche tenemos un tema bastante interesante y tenemos 3 invitados que nos van a compartir su experiencia en un tema que es bastante extenso y bastante complejo, como es el dolor cubital del carpo. Entonces, vamos a empezar a abordar el tema. Como conferencistas invitados tenemos de la Clínica Marzo al doctor Peter Reed, que es cirujano ortopedista y cirujano de miembro superior, microcirujano, quien nos acompaña esta noche desde Rochester, Minnesota. Dr. Reed, how are you doing tonight?
Good.
Thank you for joining us. Posteriormente va a acompañarnos el Dr. Brian Adams de Baylor College de Houston, Texas, quien nos va a estar hablando también, compartiéndonos parte de su experiencia en un tema un poco más específico. Dr. Adams, how are you doing?
Good evening. Great. Thank you.
Thank you for joining us tonight. Y finalmente el Dr. Meiser López de Medellín, quien nos va a estar también hablando acerca de su experiencia en otro tema un poco más específico. Ya les voy a especificar cuáles son los temas que vamos a estar abordando. Soy Julián Suárez y vamos a dar inicio ya con nuestro webinar. El primer tema que vamos a abordar es por el Dr. Peter Reed, quien nos va a hablar acerca del examen cubital de la muñeca para el diagnóstico en el dolor cubital del carpo. Posteriormente, el Dr. Adams nos va a compartir su experiencia sobre el síndrome de impactación cubital y finalmente el Dr. López nos va a hablar acerca de la artrosis radiocubital distal. Entonces, sin dar más preámbulo, el Dr. Reed puede iniciar con su conferencia examinando el dolor, el lado cubital de la muñeca. Okay, Dr. Reed.
Okay, I'm just pulling up my talk here. Okay. Can everyone see the slides?
Yeah, absolutely.
Okay, yeah. Perfect. I'm going to speak about examination of the ulnar side of the wrist. Now, the ulnar side of the wrist, it can be a little challenging to diagnose because there are so many structures that are right on top of each other. And even if we take out the nerve and the blood vessel pathologies, there's still quite a bit of structures that relate to the bone, the ligament, and the tendons. And so it can be in any combination that you can have these different structures causing pain on the ulnar side of the wrist. And that's where it's our job as hand surgeons to try to figure out what the patient has and what's bothering them. Now, a lot of times patients can't tell you that their pain is on the radial side or the midline or the ulnar side. And so my first job when someone comes with wrist pain is to try to classify them or categorize them into radial, dorsal, midline, or ulnar-sided wrist pain. If I think it's ulnar-sided wrist pain, a ulnar carpal stress test to me is a very good non-specific test for an ulnar-sided pathology. Like in this patient here where you're not really quite sure what's going on. The ulnar carpal stress test is performed in, like in this picture here, with the examiner ulnarly deviating the wrist and pushing down on the carpus and even introducing a supination pronation force. If that is painful, that's a positive ulnar carpal stress test. And if it's positive, it can mean that the patient has a Tfcc tear, like in this picture, an ulnar carpal impaction with lunate chondromalacia on the right picture, or even a loose body in the ulnar side of the wrist. So it's not very specific, but it helps you narrow your diagnosis to something on the ulnar side of the wrist. So with these 3 different structures that I'm going to talk about, we'll first focus on the bone pathologies. And these to me are the most common things that I think about when I think it's a bone-related ulnar-sided wrist pain pathology. And I'll just ask you, when you're watching this, just feel your Lister's tubercle. And if you bend your wrist down or flex it and go distal, that's your SL interval. And then if you get your thumb and place it on your pisiform and your index finger on the other side on a carpal bone, those 2 bones will move together, and that is your pisotriquetral complex, and that tells you where your triquetrum is. So keeping that in mind, we'll go through some physical exams for these common bone-related pathologies, and I won't get into specifics about how to treat these things. That's a different topic. If they have ulnar carpal impaction syndrome, they will a lot of times have a positive ulnar carpal stress test. They may be or they may have tenderness at the proximal ulnar aspect of the lunate, the styloid, or even the dorsal Tfcc. Like in this patient here, when they complain about ulnar side of wrist pain, and on these x-rays, on a neutral PA, it looks like maybe they're neutral, slightly positive. And if you get a pronated grip view, it may show some dynamic shortening of the radius or positivity of the ulna, and then on the MRI, you can see that they have classic MRI changes for ulnar carpal impaction syndrome. And that will then lead you to the fact that with the Palmer classification for these degenerative ulnar side of wrist pain or TFCC pain, that you would have a central Tfcc tear and also degenerative change at the proximal ulnar aspect of the lunate. And you're trying to draw these things out on your physical exam. Now, there can be a slightly different diagnosis called stylocarpal impaction, like in this patient here, where their pain is right at the tip of the styloid. And you can see here, it's a fairly dramatic example, but you can see that that styloid is really big and they're painful right at the tip there. But you would see that their ulna is actually neutral. Now, this patient has had trauma, but when I went in to resect the styloid, you can see how much with ulnar deviation that was impacting against the triquetrum. So that was this patient's source of pain. So different a little bit than ulnar carpal impaction. Hook of hamate fracture and non-union, that's something that sometimes it's hard to see on your plain films. The patients will say that they hurt in this area here. A really good test is to ulnarly deviate the wrist and ask a patient to resist finger flexion. And that will then put a lot of tension of your flexor tendons over the hook of hamate, and that would cause pain. One of my mentors, Dick Berger, would say that you really can't feel the hook of the hamate. I think that you can, but I believe him that he says you really can't. So if you, off of this paper here, it kind of guides you along the fourth ray, along just proximal or distal to Kaplan's cardinal line, you would have pain here, but really that flexed, only deviated exam, that seems to be the best to elicit a fracture or a non-union. Like in this patient here, they had ulnar side of wrist pain, and the radiographs just show arthritis. He's a carpenter, and he does this a lot. And when I did those physical exam maneuvers, it was positive. And so then when I got a CT scan, it showed this hook of hamate non-union. And then you can see intraoperatively that he had attritional rupture of his flexor tendons. So that was purely on physical exam. DRUJ, arthritis, that's fairly straightforward. They're tender at their DRUJ. And a lot of times when they're really ankylosed, they won't have instability. Sometimes in rheumatoids, they will. I think a good test is to squeeze across the wrist and ask the patient to supinate and pronate, and sometimes that will cause quite a bit of pain with crepitus. But usually the x-ray will show quite a bit of degenerative change. Pisal triquetral arthritis, that is also hard to see on plain films. But usually what patients will complain about, or on their exam, if you grab their pisiform and you push against the triquetrum and you go ulnar and radial pressing into the triquetrum, and you can accentuate that, but extending the wrist, that will cause pain, and that's a positive exam. Like in this patient, where based on that, I got an MRI, and you can see all the signal change within the pisal triquetral joint and the large ganglion cyst consistent with the arthritis there. And when I took the pisiform out, which I don't do very commonly, you can see how much arthritis there is. A hamate arthrosis, lunotriquetral, or a halt lesion, like in this patient here, it can be sometimes hard to see, but their pain, or this etiology, I guess, is in the patients that have a type 2 lunate, where they articulate with the proximal pole of the hamate. And in this case, you can see, at least in this cadaver, you can see quite a bit of arthrosis in the proximal pole of the hamate. They would be tender right in your ulnar midcarpal portal, so they would hurt right about here. And on this patient with an MRI, you can clearly see a large type 2 lunate with a medial hamate facet, and the MRI signal change is consistent with this diagnosis. And on arthroscopy, this is the right wrist here, you can see the large type 2 lunate, the medial hamate facet, and then looking up at the hamate, you can see all that arthrosis that a lot of times you can only see on an MRI, but a lot of times you diagnose it on your physical exam. And I do a diagnostic injection here too to see if they get better with the mid-carpal injection. Switching gears to the ligament side, these are the different soft tissue things that would cause patients ulnar side of wrist pain. Tfcc tear, I'll go through pretty quickly because I think everyone is fairly familiar with this. I'll just remind you of the traumatic palmar class 1 type of etiologies for Tfcc tears. You can do this supination lift test or a modified press test, and if it hurts you with either of these, it may indicate a dorsal or a volar peripheral tear. If any of them are positive, then I think any type of peripheral tear. DRJ instability, I think everyone knows how to do, but the one comment I'll make is not to grab here, because if they have, that sound is there, if they have ECU tendonitis, they will hurt there, so grab a little more proximal so you're not causing pain by doing this. But you would test to the other side and test them in neutral, full supination, and full pronation, which is fairly non-specific and it's observer dependent, but it's a good tool. Like in this patient that had a foveal tear and they had DREJ instability, which then I fixed down the road. And here with an arthroscopic pull test through the prestyloid recess, you can see that it's pulling with me to indicate the unstable foveal tear. Or this patient that is maybe slightly ulnar positive and they have tenderness at the DREJ, and that's consistent with a, at the TFCC region, and that's consistent with a central tear. UT split tear is something that one of my partners, Dick Berger, described, and this would be positive with a foveal sign, which is putting your thumb, here's FCU, here's ulnar styloid, and there's a soft spot there, and if you press there, it will hurt. Normally it hurts, but a positive exam is it hurts more than the other side, and it reproduces their pain. And if that's the case, they may have a tear of the UT ligament, which it's really hard to see on an MRI, but it would be right about here on this sagittal. And then intraoperatively, here's a UT, and once you clean that out, then you see that split tear, and then that usually I just repair with 2 horizontal mattress sutures. And then LT ligament injuries, like in this patient, I know they have an SL tear, and everyone focused on that, but they had a lot of ulnar side of wrist pain, and this was really a a spectrum of a perilunar injury, and they were tender right along the LT interval. There's a lot of different tests that you can do. An ulnar snuff box test, which is just on the, I'm going to pause this here, it's right on the ulnar border of the triquetrum, pressing into the LT, that would hurt. Another exam is the LT shuck or ballottement test, which is really grabbing the LT on one side, like so, and the lunate on the other, and just trying to move them relative to each other. A slight variation is a shear test where you keep the lunate stable and you move the triquetrum. So I would have turned that off there, but you get the gist. It's just trying to move the triquetrum relative to the lunate, and that would cause pain. And here in this patient on the right side, that's their SL, but you can see on the image or the video on the left side of your screen, that's me doing a shear test. I'll go back here, and then you can see the instability there on that patient. And then DREJ ligament sprain or tear, that would typically cause pain with doing your DREJ stability, or it would even cause instability if these are torn. I'm just going to go quickly here, interest of time. I'm going to skip through there. And in this patient here, who was fairly unstable, and they had a normal appearing sigmoid notch, but when I went in from their traumatic event to look at their volar distal radioulnar ligament, you can see that that's torn here. All right, lastly with tendons, these are the most common things that I think about for ulnar side of wrist pain. ECU tenosynovitis, I think everyone sees quite a bit. The synergy test to me is one of my best tools in diagnosing this. Doesn't have to be positive, but a patient when they're supinated, it puts stress on the ECU, and if you ask them to resist adducting or pulling together the thumb and the middle finger, that will synergistically make your ECU fire, and that will cause pain. Or on this MRI in this patient, you can see that they have a lot of T2 signal intensity in the ECU. And on after they fail non-operative treatment, you can see how much tenosynovitis there is over the ECU tendon. Now you can have ECU subluxation or instability, like in this patient here on the MRI, you can see that ECU is sliding ulnarly instead of sitting in the groove. And this is from the internet, but you can see that instability that's really elicited in supination and wrist flexion. Patients will flip over there. EDQ tenosynovitis, that's not very common, but in patients that have had a previous dorsal approach to DREJ, if the EDQ is left intact in the fifth extensor compartment, that can hurt. This patient here had no previous surgery, and they hurt over the EDQ on my resisted finger extension test on the small finger. And here, intraoperatively, you can see they have a very, very low muscle belly of the EDQ, and that was purely on physical exam, because looking back at the MRI, I really didn't see all that that low muscle belly here. So stressing the importance of the physical exam. And lastly, SU tenosynovitis. A lot of patients you'll see calcific tendonitis, but again, they would be tender right at the insertion of the FCU, and with resisted wrist flexion over the FCU, that would cause pain. So if you could take anything home from this talk, the patient's history and chief complaint will really help guide you towards what the ulnar side of wrist pain pathology is. And if they can't tell you that, I first try to figure out if it is ulnar side of wrist pain, and then I do very focused physical exam findings on the ulnar side to figure out if it's bone, tendon, or ligament type of injury. And in my practice, I inject a lot just to figure out if that's their pain generator. Thank you very much.
Thank you, Dr. Great lecture, very complete, and a lot of pathologies. So it's a very difficult diagnosis every time you face one patient with this kind of symptom. But thank you very much. At the end of the webinar, we're going to have a small Q&A session, so please stick with us for the end of the webinar, okay? Thank you very much. So right now, we're going to continue with Dr. Brian Adams, who's going to talk about the ulnar impaction syndrome. Dr. Adams, good evening. How are you doing tonight? Thank you for joining us. So the audience is yours. Dr. Adams, please open your mic.
Okay.
Okay, Dr. Adams, thank you very much.
Yes, I muted my mic so that I wouldn't interrupt anybody. And I'm waiting to see the slideshow here.
Yep.
There we go. Well, thank you for inviting me. It's a real pleasure. And I hope to get to know more of you in your local area, more of the surgeons. It's certainly a pleasure of mine to meet as many international hand surgeons as I can in my career. And it's been very helpful to be involved in these sorts of activities. And I'm sure Peter shares the same approach to this, and we hope to support you more in the future. You asked me to chat a little bit about ulnar impaction syndrome, and specifically its treatment. And I think Peter did a good job of the assessment from a clinical point of view for diagnosis and some of the classification point of view, and I'm going to expand on that. So ulnar impaction syndrome is relatively common because the ulnar side of the wrist is really at risk for overloading relative to its structural abilities, if you will, based on its joint contact surfaces. So sort of by definition, ulnar impaction syndrome is chronic and excessive ulnocarpal loading. And the patients that are most at risk for this are those with positive ulnar variants. So the definition and the essentially the structural diagnosis is not terribly difficult once it's established itself. Sometimes it's difficult to make the diagnosis early before we see radiographic changes. The patients at most risk for positive ulnar variants are those that have a traumatic ulnar variance, and the classic there is just a radius fracture with shortening. There's other reasons to have an acquired positive ulnar variance. It might be related to changes in development and so forth. I'm not going to cover that in any great degree. And then there's the normal variant, which is somewhere between 10 and 20% of the population can have positive ulnar variants. And then there's the group that's physiologic, and that's where we find that during power grip, the radius might migrate slightly proximal, allowing the ulnar to be slightly longer and causing this increase. So ulnar impaction syndrome, as Andy Palmer defined it some time ago, was this group of changes in the class D, as Peter talked about, that's typically begins with a central perforation of the TFC. After that, the order in which the degeneration occurs is quite variable. Typically, it was described that ulnar head chondromalacia progresses next, followed by lunate chondromalacia, and then LT ligament perforation. But in my years of practice, I've seen a variation where sometimes not even a central perforation is present, and yet an MR scan or arthroscopy will see a lot of changes in the ulnar head or in the lunate. So be aware that we can have any combination of these findings in ulnar impaction syndrome. The typical findings, as I mentioned already, is where we see cystic changes of both the ulnar head and the lunate, or just one of them. And then by arthroscopy, we've learned more about the natural sort of degeneration of this overloading. And there's fibrinous changes of the lunate, mostly on the carpal side, but it also can involve the triquetrum. The LT joint becomes degenerative, and then the central perforation followed by, if you will, at least identification of the chondromalacia of the ulnar head. And I think with MR scans, when they're available to you, you can sometimes pick these up a lot earlier than we could just with standard radiographs, where we see these edematous changes, in this case on the MR scan showing up in the triquetrum. So just as a bit of a side, when arthroscopy became very common and in terms of treatment of the ulnar side of the wrist, I remember when I first started doing arthroscopy, it was a lot of fun to go in there and clean up these Tfcc central tears, thinking I was doing a lot of good for these patients. And then sometimes I think I was, but what we have to be careful of is deciding or assessing, why did these patients have this in the first place? So if you see a degenerative tear and you clean it up arthroscopically, are you really changing the natural history of this? Well, there's been a couple studies that have looked at this to say we probably don't. In this case, I'll just read it. Simple debridement had little value on the clinical course of recalcitrant wrist pain. And then they went on to find that if they did an ulnar shortening osteotomy in that group with degenerative changes, that they had a measurable benefit. So what that's starting to tell us is you need to treat the underlying cause, not just the result of the underlying cause, i.e. the degenerative Tfcc tear. And here's another study that was similar to that, showing us that if you have degenerative changes, that simple debridement again didn't do very well. But the positive finding in this study that gives us some hope here is if you miss it in the beginning and you go back and do an ulnar shortening osteotomy later, that those patients still did well. And that's been my experience also. And I've been more and more in my practice as I've gotten older, I'm more of a fan of ulnar shortening osteotomy for these various overloading problems on the ulnar side of the wrist. So what are our surgical options to sort of unload, if you will, the ulnar side of the wrist? There's the traditional shaft shortening osteotomy, basically shortening the ulnar shaft so that the ulnar dome isn't as prominent distally. Still, I think the #1 procedure that's done in the US and worldwide. We also have the open wafer procedure originally described by Paul Feldon, which we're basically shaving off the dome of the ulna. Then we have it done arthroscopically, typically through the degenerative tear of the TFC, and then also underneath it. And then the newer procedure that's being popularized, and some people very much liking this over other options, and that is metaphyseal shortening of the ulnar head itself. But let's talk about the ulnar shortening osteotomy through the shaft. What are the theoretical positive effects? Well, certainly, as I already mentioned, we're decreasing the load across the ulnocarpal joint, particularly if it's an acquired one. Many years ago, in Andy Palmer's lab, they looked at that and found that in patients with acquired positive ulnar variants, they can increase their load across the ulnar carpal joint by as much as 100%, or to say it another way, it goes from a standard 20%, which is the typical load across the ulnar carpal joint, up to 40 or 60% of the overall load of the wrist, which is obviously a lot when you're transferring that much. So we are unloading it, which can have positive effects for any degenerative tears. And my talk isn't about traumatic tears, but the same thing applies for that. If we see somebody with a central 1A tear or a 1B tear, you have to ask yourself, is simply repairing the TFC going to be enough if we really haven't changed the environment of the TFC? So again, I have a low threshold to do an ulnar shortening osteotomy in that group to essentially allow my traumatic repair to have the chance to heal. And finally, a theoretical positive effect is that we're tightening the ulnocarpal ligaments, as Peter alluded to, by shortening the ulna. So both the ulnotriquetral and ulnolunate ligaments, in theory, will become somewhat more taut, and we might even help the LT ligament to become more stable. So those are our theoretical and I think clinically relevant important points for ulnar shortening osteotomy. So as you apply that, as I mentioned a little bit already, for an ulnar shortening shaft osteotomy, we can consider it an ulnar impaction, and I'm going to talk a bit more about that. TFC injuries I just mentioned, lunar-triquetral ligament injuries, acquired deformities, particularly if they're also causing DRUJ instability. A few congenital deformities may be addressed by this, the variants of Madelung's. And then even DRUJ arthritis can be helped by shaft shortening osteotomy. That was primarily out of a study by Watson, but also others. And it essentially is the same for the orthopedists in the audience of changing the contact surfaces like that is done for the knee and occasionally other joints. And so by shortening it, you might decrease your ulnar impaction, but you also might affect the DRUJ arthritis by putting some better cartilage, if you will, against the sigmoid notch. Be careful when you do this, however. I've tried it a couple times, is many times when the ulnar head shows chondromalacic changes, they're worse than what you might think. There's more degenerative changes. So you have to be a little careful in applying this too liberally to older folks, but to younger people, I think it's a good option for DRUJ arthritis. So the classic ulnar impaction is, again, here's a case with a combination of a TFC peripheral tear and ulnar impaction, not an uncommon problem following a distal radius fracture where there's shortening of the radius. You can see this one also had an ulnar styloid fracture. And I don't think we would want to do just a TFC repair in this one because it's just going to be, again, hyper-loaded, excessive load. So in this case, we're treating both the ulnar impaction as well as it allows us then to repair the TFC. The TFC literally wouldn't even be able to make it to the fovea for peripheral repair. But in this case, by shortening the ulna first, it unloads the ulnocarpal joint, and now we have enough space, if you will, and proper tension to repair the TFC. And here's a similar case where there's subluxation of the distal ulna, And so by an impaction and by shortening the ulna, we're able to restore that, and we can essentially ignore the malunion. This one wasn't fixed very well of the distal radius because this patient's problem was on the ulnar side of the wrist. Here's a case where ulnar impaction was missed. The surgeon tried to repair the LT ligament, and as I mentioned before, ulnar impaction eventually can cause, or one variation of ulnar impaction can cause LT ligament injuries. So in this case, we unload the ulnocarpal joint, and we did not even need to address essentially the failed LT ligament repair. And here's a case where ulnar impaction, again, a severe case. This is a very late case of physeal arrest in which there's ulnar impaction and DRUJ instability. And by a major ulnar shortening osteotomy in this relatively young 17-year-old female, we were able to essentially restore that joint surface and restore stability at the same time. So don't be afraid to do a substantial ulnar shortening in these types of patients. You don't necessarily need to do a radius osteotomy in this group. Here's a case of essentially a congenital deformity and a Madelung's. And the reason why I like to show this case is sometimes you have to be a little bit ingenious about the contouring of your plate in an ulnar shortening. The plates typically that we use are flat, but if you do this in a curved ulna and you shorten the ulna, then what you might do is introduce DRUJ instability because it's no longer following the curvature of the radius. So again, keep this in mind when you're doing somebody with an a developmental deformity. In this case, we see another one, again, ulnar impaction. And in this case, I'm a bit worried, as you notice the sigmoid notch is not very tall. It's a very narrow sigmoid notch. So you have to be careful about over shortening an ulna in ulnar impaction syndrome when the sigmoid notch is not very tall, because I have done it inappropriately once before where I brought the ulna so proximal that it was actually mostly articulating with the distal metaphysis rather than the sigmoid notch itself. So be careful of that. There's a lot of discussion about in ulnar shortening whether it's appropriate if you have a reverse sigmoid notch. In other words, the inclination is from distal radial to proximal ulnar, so that when you shorten the ulna, as shown in this case here, your contact surfaces might not be parallel, and this may affect increased chance of arthritic changes in the DRUJ. Andy Palmer looked at this in a group of patients and found that it indeed did lead to radiographic, more rapid changes of the DRUJ, but these did not correlate with clinical outcome. There's been additional evidence by MR scans that what we see radiographically on plain radiographs like this one doesn't necessarily tell us what the articular cartilage surface is. So in many of these cases that look like reverse inclinations, the cartilage itself is still quite vertical. So that's good news for us in doing ulnar shortening osteotomies, but still be careful about creating too much incongruity. What are the complications of shaft osteotomy? Well, I think if you do an overzealous bone stripping of the periosteum, then you can have a higher incidence of non-union. It supposedly is helped by placing an oblique screw across an oblique osteotomy, and that's what I do now. But I think more important to get a constant healing rate is not to do a circumferential bone stripping as was originally described for this procedure. I think you only need to do it on the surface that you're going to apply the plate, and then at a short area at the osteotomy site, and don't strip the bone on the opposite side. Plate removal is another complication. I have, in my entire career, which early on people didn't believe me, but I still like to place the plate dorsally. And the reason why is if you think about, most people are resting their forearm on the edges of tables using a computer like we are tonight. And if you put the plate volarly, you're actually resting on the plate. And I think more patients are irritated by that. The original reason why we avoided putting the plate dorsally like I like is they thought that it would create ECU tendonitis. If you don't put it too far distally, and that is really distal on the neck, I don't think it causes any irritation of the ECU. Also, people described that it was better to place it volarly because the bone is flatter on the volar surface than it is dorsally. I would argue that it's actually flatter on the dorsal side. So it's something to consider. It's certainly not a game changer for everyone, but that's what I've done, and I've removed so few plates that I'm going to continue to do it that way. If you happen to have the arthroscopy available to you and you want to assess the ulnocarpal joint for the reasons that Peter went through, that I agree with, that there could be things going on in the wrist that you can't identify easily by x-rays or MR scan, or you want to do some sort of trimming and cleaning of the joint, then by all means plan to do the two together. I think it's easier to do the ulnar shortening osteotomy first, especially in somebody that's severely ulnar positive, because then you make more room, if you will, for your wrist scope. So, and but plan to do both from the outset. I find using an arthroscopy traction tower, whether I decide to do arthroscopy or not, is very helpful. It's a good assistant. It puts the forearm upright where you want it, and you can do the entire procedure even without an assistant, because basically the traction tower becomes your assistant. There are new technologies that might be available to you that are dedicated for ulnar shortening osteotomies. I think they make it faster and easier and maybe more accurate. I don't think it's actually necessarily improving my particular healing rate, but I do use them. I would not be afraid at all, however, of using a standard 3-5 screw type of osteosynthesis plate. I think if you use proper technique, they work fine. Then you can use an oblique screw, as I mentioned already, in that group. You can, I think, no matter what system you decide, you can certainly use various different tricks in the patients that you need to do a lot of shortening. I've done many shortenings of a full centimeter. You can use, again, different techniques. If you use one of the dedicated systems, like I'm showing here, then you can sometimes do sequential cuts and allow you then to keep your precision as you make as in this case, 1.5 and 1.4 millimeter cut in order to make it more excessive. If you do it without one of these dedicated systems, be very careful. You have to control the ulna. Sometimes clamping a plate on preliminarily will help hold the plate. Help hold the ulna in alignment as you make your cut, and that can be helpful. So other alternatives to shaft osteotomy, as I mentioned, are the open wafer procedure. I think this is not done very often anymore, except for I will still do this in patients where I'm doing more complex surgery. For instance, somebody that I'm doing a four-corner fusion on, or maybe a PRC or a total wrist arthroplasty. I think through a separate capsulotomy, you can do a dome resection quite quickly and close the capsulotomy dorsally. And I think that works well. In the most series, however, it's been shown that the open wafer tends to take a little bit longer to recover from than an arthroscopic wafer. But again, the final result's probably the same. So I think whatever works best for your practice. And then in the other one to mention, as I did in the beginning, is a metaphyseal osteotomy. Again, that's the concept there is a little bit newer. And that the idea here is that you're going to hinge the bone on the periosteum, take a wedge out, and then shorten it. And people have done these wedges from both different ways. They've made the wedge with a ulnar hinge and made a wedge also with a radial hinge. So I think both of them can be done. Most people would use the ulnar hinge and shorten it. I don't have as much experience with this as others do, and I would invite you to read those articles that I think are well done that describe this in detail about some of the nuances, because it is a technically challenging operation in some cases. be careful when you do, here I'm sorry I'm out of sequence a little bit. I hit the wrong button earlier when I was loading my talk. When you do a arthroscopic wafer resection, to go backwards a little bit, be careful that, and this also applies to metaphyseal osteotomies, be careful that you do not create such a small amount of contact surface against the radius that you cause excessive loading, as happened in this case, which was referred to me, where this failed wafer resection because of that too much removal of the bone. So the classic teaching on either arthroscopic or an open wafer is to remove no more than 4 to 5 millimeters of the head. But in reality, I think it's not so much how much you remove, it's how much you leave behind. So, and that's the reason why this one failed. So in some patients, the ulnar head's quite tall, and you can remove even more than 4 or 5 millimeters in doing a wafer resection, and yet still have enough contact surface. Whereas in other people, removing 4 or 5 millimeters may leave you only with a couple millimeters, and that's just prone to have a poor outcome. In that particular case, I converted it to a ulnar head replacement, which maybe you have available to you. So, and again, I'm sorry, out of sequence. This one is the metaphyseal shortening osteotomy. Again, a good description of the technique that's being done, and certain people believe that this is much easier to do in their practices and a lower revision rate. However, there's been some discussion about actually a higher complication rate for this procedure. So I think that just tells us that it's technically a bit more challenging. So if you're doing a ulnar shortening through the metaphysis, it's mandatory you maintain the periosteum, otherwise the blood supply is cut off to the ulnar head. You want the screw to be centered in the head, and you want to engage the ulnar cortex so that you actually do get good compression of the osteotomy. So its potential advantages: some people believe it's more rapid union. There's no hardware irritation like a plate. Complications I already mentioned is it can, on the ulnar side, have some prominence. You can have hardware loosening. In this case, if you get hardware loosening, it can lead to head fracture and other problems. So I'm going to close with that. Many people think the DRUJ and it is drudgery, dull, irksome, fatiguing, work, and uninspiring. But I hope this will maybe make it a little easier for you, that it's not quite that bad. Thank you.
Thank you very much, Dr. Adams. Great lecture. Very interesting. And a lot of things to discuss at the end as well. So now, Dr. López, muy buenas noches. Abre el micrófono, por favor.
Ready? Hola, buenas noches a todos.
Ahora sí, bienvenido, Dr. López.
Gracias.
Muy buenas noches. Gracias por acompañarnos aquí en este webinar. Entonces puedes compartir la pantalla. En este momento el Dr. López nos va a hablar acerca de la artrosis radiocubital distal y toda la experiencia que él tiene para compartir en el manejo de este tipo de patología. Wafer, el auditorio es tuyo.
Ok, muchas gracias a todos. Gracias por esta invitación. Realmente honrado por estar compartiendo este espacio con autoridades y profesores tan renombrados como el Dr. Peter Ree y el Dr. Adams. Thank you very much. Ok. Han hablado un poco ya sobre grandes elementos de la anatomía de la zona radioulnar distal, ¿sí? Y de todo lo que implica alrededor del dolor, cuando hablamos de dolor radioulnar distal. Entonces, básicamente, el dolor que ya ha referido el doctor Ree y el doctor Adams, hablando de impactación unocarpiana, de incongruencia, ¿cierto? Hacen parte de todo este complejo. Sin embargo, el tema de la artrosis también está relacionado con estos dos anteriores, ¿cierto? Y en algunas ocasiones con una aparición primaria o de etiología desconocida de la artrosis. La artrosis, como normalmente la conocemos, ¿cierto? Es una enfermedad que altera a nivel de la articulación, el cartílago hialino, y por diversos factores puede conducir a la alteración biomecánica y al dolor. La artrosis se ve en todas esas articulaciones y la tasa de incidencias va más o menos en este orden, ¿no? Cadera, rodilla, columna, hombro, codo y muñeca, siendo una de las más importantes, pero también una de las más incapacitantes. Desde el punto de vista de la anatomía, muy importante todo lo que se ha mencionado. Pero no olvidar que la articulación radioulnar distal es una articulación tipo trocoide, ¿de acuerdo? Y que este movimiento, por simple que parezca, ¿cierto?, tiene implícitos algunas particularidades dada la gran variabilidad anatómica que presenta. Entonces, esta articulación tiene, de acuerdo a los estudios, una gran variabilidad anatómica, como la vemos acá. Entonces, dentro de estas consideraciones anatómicas de esta articulación es importante recordar unos aspectos importantes como la asimetría de los radios de curvatura. El radio de curvatura de la cavidad sigmoidea del radio y el radio de curvatura de la cabeza radial son bastante diferentes. Esta asimetría genera unas zonas de contacto diferentes. Por ejemplo, la zona de la cavidad sigmoidea es 4 a 7 milímetros mayor que la cabeza ulnar. Y esto permite que al igual que en la glenohumeral, se dé no solamente un movimiento de articulación trocoide, ¿cierto?, sino también un movimiento de traslación, ¿sí? Se da un movimiento de traslación por tener una diferencia en los diámetros de curvatura. Ahora bien, también existen unas diferencias importantes en cuanto a la anatomía de esta articulación. Cerca del 55% de estas articulaciones son paralelas, cerca de un 33% son oblicuas y el 12% son oblicuas reversas. Ahorita hablaban del tema de la oblicua reversa y del cuidado que debemos tener cuando vamos a hacer una osteotomía de acortamiento ulnar, que si tenemos una articulación con una anatomía reversa como esta, podemos aumentar la zona de carga y esto podría aumentar el riesgo de artrosis radioulnar distal. Otros aspectos en la imagen coronal de la anatomía son, por ejemplo, que hay articulaciones planas, hay articulaciones con una inclinación reversa hacia el dorso, otras en C y otras en S. Todas estas diferencias hacen que esta articulación no sea simplemente una articulación trocoide de un tornillo sobre un socket, ¿cierto?, sino que le dan cierta complejidad a esta articulación. Y esto va de la mano con el riesgo de artrosis cuando hay mala unión, por ejemplo, a nivel del radio distal. Entonces, tenemos acá, por ejemplo, esta imagen radiográfica donde tenemos la muestra de que hay unas articulaciones paralelas, unas articulaciones oblicuas y otras reversas. Y esto definitivamente es muy importante a la hora de hacer una osteotomía de acortamiento. Aquí otros estudios que hablan de la porción articular a nivel de esta zona. Solamente el 69% realmente está cubierto por cartílago y el 31% no. Aquí vemos la diferencia del radio de curvatura. La versión del ángulo también estudiada en estos artículos. La profundidad, muy importante. La profundidad es tan solo máximo de 1.67 milímetros. Esto da cuenta de la importancia que tiene en la estabilidad toda la estructura ligamentaria alrededor de esta articulación, tal como pasa, por ejemplo, con la glenohumeral. La varianza ulnar, por ejemplo, este es un concepto que sabemos que es un concepto dinámico, y de ahí entonces la importancia que cuando estemos hablando del diagnóstico, de si existe o no una varianza ulnar, hagamos las radiografías de manera adecuada. Ahora más adelante vamos a mencionarlo. Entonces, en este concepto ulnar, de varianza ulnar dinámica, la carga puede pasar de un 20 a un 42% al trasladarse 2.5 milímetros, que es lo que se traslada cuando hacemos movimientos de pronosupinación. Aquí un ejemplo radiológico de esta dinámica. Esta articulación ha sido objeto de múltiples estudios, tratando de evaluar entonces esta curvatura, las diferencias que existen y la estabilidad que le proporciona tanto la cavidad ósea o esta relación ósea radiocubital como las estructuras ligamentarias alrededor. Aquí un ejemplo de cómo va creciendo la zona articular desde palmar hacia el dorso. Entonces miren que siempre existe una asimetría en esta articulación. Y esto precisamente es lo que debe llamar la atención cuando tenemos, por ejemplo, una mala unión a nivel del radio distal. Entonces debería uno considerar como uno de los criterios importantes a la hora de evaluar la indicación quirúrgica de una fractura del radio distal, cuál es la relación que tiene esta cavidad sigmoidea con la cabeza ulnar, para poder determinar incluso si puede existir una indicación de cirugía solamente con ese criterio, para mantener la articulación radiocubital distal con una adecuada relación. Entonces las causas, cuando hablamos de artrosis, hablamos de que la artrosis radioulnar distal, ¿cierto? Puede tener causas inflamatorias, degenerativas, postraumáticas y algunas incluso posquirúrgicas. Por ejemplo, cuando hacemos una osteotomía de acortamiento y de pronto cambiamos las zonas de apoyo de esta articulación y existe una mala unión a nivel del radio distal. Causas primarias más frecuentes en las mujeres, sobre todo cuando hay una impactación ulnocarpiana, y más causas secundarias cuando hay una incongruencia o una inestabilidad, o por ejemplo infecciones o artritis reumatoidea. Tenemos acá un ejemplo de una mala unión que definitivamente va a causar alguna alteración biomecánica a nivel de la articulación radioulnar distal y con ello un riesgo importante de una artrosis. Y aquí una artrosis radioulnar distal de origen degenerativo. De nuevo, cuando hay una mala unión a nivel de radio distal, debemos ser muy exigentes con la reducción y de ahí la importancia de la tomografía dentro de la evaluación diagnóstica de las fracturas del radio distal. Por ejemplo, cuando tenemos una tomografía, ¿cierto? Esta imagen que a veces pasa desapercibida, ¿cierto? Y siempre nos enfocamos un poco más en la imagen sagital y coronal. Esta imagen axial es importante para poder determinar cuál es la relación y que debemos exigirnos a la hora de hacer la cirugía cuál debe ser la reducción anatómica a nivel de esta articulación para evitar una artrosis. Hay muchos estudios, hay unos estudios muy bonitos alrededor de la articulación radioulnar distal. Por ejemplo, en este estudio estaban evaluando en muñecas no lesionadas y en muñecas lesionadas cuál era, a pesar de tener una cinemática normal de la radioulnar distal, es decir, movimientos adecuados, cuáles eran las zonas de contacto. Y definitivamente hay una alteración de las zonas de contacto. Y si a esto le sumamos la variabilidad anatómica, definitivamente no todos los pacientes van a hacer artrosis, pero si se conjugan algunos elementos como la mala unión y algunas diferencias en la articulación radioulnar distal, por ejemplo, una articulación con una inclinación reversa, podríamos estar frente a un paciente que puede tener un riesgo mayor de artrosis a futuro. Este es un paciente que tiene un pinzamiento urnocarpiano que se lleva a cirugía para un acortamiento, tal y cual como lo hacemos de rutina en un paciente, ¿cierto? Y sin embargo, este paciente continúa posteriormente con dolor y a futuro vemos cómo este paciente logra hacer una artrosis radioulnar distal. Miren que esta es una articulación reversa, ¿de acuerdo? Entonces, esto aumenta el riesgo de dolor y de artrosis en esta articulación. Aquí hay un estudio muy interesante de acortamiento radioulnar, de acortamiento ulnar, un estudio de 10 años, donde lograron determinar, por ejemplo, que el acortamiento ulnar altera la congruencia articular y puede incrementar este riesgo en este tipo de articulaciones, cuando hay una articulación o una orientación reversa. Entonces uno podría incluso pensar que es muy importante, evidentemente, ¿cierto?, evaluar no solamente si hay una varianza ulnar positiva para hacer el acortamiento, sino el tipo de articulación que tenemos. Cuando hablamos del diagnóstico, ya el doctor Peter nos ha mostrado desde el punto de vista semiológico cómo podemos evaluar. Sin embargo, es importante tener claro que el dolor, el movimiento y la inestabilidad siempre debemos evaluarlo de manera comparativa. Y existen dos pruebas muy importantes para hablar de artrosis radioulnar distal desde el punto de vista semiológico. La prueba del cizallamiento, que nos la demostró ahorita el doctor ¿cierto? Y la prueba de la carga ulnar. Le aplicamos carga a nivel de la muñeca, un poco más proximal en el antebrazo, y le pedimos al paciente que haga movimientos de pronosupinación, en esta que está acá, ¿cierto? Estas dos, ¿cierto?, son muy orientadoras, muy sensibles para hablar de artrosis radioulnar distal, esto más las imágenes evidentemente diagnósticas. En este artículo nos hablan, por ejemplo, de la varianza ulnar y de la configuración articular, del pinzamiento con carga, de los signos de desgaste articular y hacen las recomendaciones, que es lo que debemos tener en cuenta. No sé realmente cuántos de nosotros, cuando ordenamos las radiografías, lo hacemos de esta manera o vigilamos que el técnico de rayos X lo haga así, ¿cierto? No sé si realmente todos lo hacemos, pero la radiografía para evaluar la articulación radioulnar distal tiene unas consideraciones importantes. La radiografía AP debe ser en abducción de 90-90 con la muñeca en neutro y la lateral en aducción a 90 grados el codo y muñeca en neutro, para poder evaluar de manera adecuada la varianza ulnar y si existen o no alteraciones a este nivel o pinzamientos. Aquí tenemos un ejemplo de una impactación ulnocarpiana con una radiografía supinada y aquí pronada con puño cerrado. Esto es algo que es un elemento básico dentro de la evaluación radiológica y deberíamos utilizarlo de rutina para evaluar esta articulación y poder determinar si el paciente se beneficia o no de un procedimiento tipo osteotomía o de otra. De nuevo acá, ¿cierto? artrosis radioulnar distal. El diagnóstico es importante, en el diagnóstico es importante tener en cuenta la tomografía cuando queremos ser un poco más acuciosos, y nos aporta realmente bastante información la tomografía. Nos aporta bastante la tomografía para poder determinar si existen o no, por ejemplo, cuando hay malunión del radio distal, cuál es la relación que existe entre esta articulación, entre el cúbito y el radio, si la articulación es inestable o no, y determinar incluso el adelgazamiento del cartílago articular, algo que también podemos ver con la resonancia, el adelgazamiento o la condromalacia a este nivel, que nos puede hablar de este tipo de alteraciones. Aquí de nuevo la importancia de la tomografía en la evaluación y para tener en cuenta dentro de los criterios clínicos de una fractura del radio distal con indicación o no de cirugía. Desde el punto de vista de tratamiento, entonces debemos tener en cuenta lo siguiente: cuando estamos frente a una artrosis radioulnar distal, hay que tener en cuenta cuáles son las comorbilidades y las causas de esta artrosis, la edad y la actividad física de este paciente para poder establecer cuál puede ser el tratamiento adecuado. La expectativa funcional y la actividad laboral es muy importante. Existen múltiples posibilidades quirúrgicas, entonces esto es importante a la hora de establecer cuál puede ser el tratamiento y los tratamientos previos, teniendo en cuenta de manera muy clara que siempre debemos comenzar con un tratamiento no quirúrgico, es decir, un tratamiento conservador. Entonces, dentro del tratamiento, el tratamiento conservador es el elemento fundamental, un tratamiento conservador adecuado. El tratamiento conservador más la infiltración sirve de prueba terapéutica, y desde el punto de vista quirúrgico, la artroplastia, interposición, las artrodesis y las prótesis radioulnar distal en sus diferentes variantes. Por ejemplo, aquí tenemos un paciente que puede ser de manejo no quirúrgico a pesar de que tenga dolor radioulnar distal, y podríamos manejarlo con fisioterapia, con una ortesis simple, que ahora les vamos a mostrar cuál es, y incluso podríamos llegar hasta una infiltración. En este caso, no hay dudas que este paciente, si está sintomático, requiere un tratamiento quirúrgico. Hay que modificar actividades, fisioterapia, AINES e inmovilización, hace parte siempre del tratamiento no quirúrgico de estos pacientes. Y aquí tenemos un ejemplo de una ortosis a nivel de esta articulación radioulnar distal, más utilizada para los pacientes o los cuadros clínicos con inestabilidad. Pero cuando logramos estabilizar esta articulación con esta prótesis muy simple, logramos darle al paciente un alivio del dolor cuando todavía no tenemos unas indicaciones claras de cirugía. Y esta puede ser una de los acompañantes de este tratamiento no quirúrgico. Ahora bien, desde el punto de vista quirúrgico, tenemos diferentes opciones. Artroplastia de resección tipo Darrach o hemiresección, un Sobeca-Pangi. El Darrach, que tuvo un gran auge, ¿cierto?, hace ya varias décadas, hoy en día es poco utilizado. Sin embargo, yo debo confesar que lo utilizo con frecuencia en pacientes de edad avanzada, en aquellos pacientes en quienes la exigencia física es poca, ¿de acuerdo? La literatura más actual ha determinado que muchos casos de estos pacientes, cuando se aplica en edades jóvenes, por ejemplo, pues los resultados no son adecuados. La casuística personal, pues, no es mucha, por ahí alrededor de 10 o 15 pacientes en los que hemos utilizado este procedimiento, pero ojo, en pacientes incluso mayores de 60 años con artrosis o artritis a este nivel, y los resultados clínicos han sido muy alentadores. La prótesis puede ser parcial o total, y el salvamento, que se utiliza cuando hay falla de la prótesis, por ejemplo, que es una resección en 25 a 50%, una sinostosis o un antebrazo de un solo hueso. Esto ya sería uno de los extremos quirúrgicos de esta lesión. Entonces, el Darrach, por ejemplo, tiene unas características importantes. Un paciente de edad avanzada con poca demanda física se va a beneficiar de esta cirugía. Evidentemente tenemos que hacer algunas plicaturas alrededor del muñón que queda para que no quede inestable y que pueda tener algo de agarre sin síntomas. Algunas imágenes acerca de las diferentes técnicas que se describen para esta cirugía de Darrach, muy elaboradas, pero todas tratando de darle estabilidad a este muñón, que es en últimas lo que probablemente puede generar dolor en el postoperatorio. 93% de buenos resultados y un 44% de traslación ulnar, por eso indicado más en pacientes de edad avanzada. Este es uno de los ejemplos en los que se ha usado. No es un ejemplo nuestro, ¿cierto? Pero en algunas ocasiones hace parte del manejo para evitar el dolor radioulnar distal. En este caso, pues este es un carpo que no se va a trasladar, ¿cierto? Pero este paciente tiene un buen resultado cuando hablamos de dolor. La hemiresección o Bowers, ¿cierto? Este tipo de cirugías que permiten mantener cierta estabilidad del complejo ulnocarpiano, pero que alejan el dolor cuando logramos quitar o anular esta articulación radioulnar distal. La cirugía tipo Sobeca-Panchi, ¿cierto? Un poco más utilizada en pacientes que requieren fuerza o en pacientes más jóvenes. Tampoco tampoco tiene muchos adeptos esta técnica. Sin embargo, ¿cierto? Yo la utilizo en algunos pacientes en pacientes jóvenes, por ejemplo, con algún tipo de alteración de radioulnar distal, principalmente cuando hay secuelas, por ejemplo, de malunión del radio distal, y es más difícil hacer una osteotomía del radio distal y tratar de recuperar esa articulación. Existen también diversas técnicas quirúrgicas para esto, para tratar de lograr la consolidación y estabilizar el muñón proximal. Este es uno de los esquemas que nos proponen para este tipo de cirugías. Fijación con 1 o con 2 tornillos, ¿cierto? Ideal con 2 tornillos o con un tornillo y un pin para dar suficiente estabilidad. Otras técnicas, la modificada, por ejemplo, un poco más de pronto invasiva, ¿cierto? Y hay que hacer una perforación bastante grande en el radio. Esta técnica personalmente no la he hecho. Entonces, la no unión y la inestabilidad, ¿cierto? De los dos extremos es muy importante. Estos son los dos elementos a tener en cuenta. Aquí tenemos, por ejemplo, este estudio que habla de la fijación con un seguimiento a 8 años con 105 pacientes. Buenos resultados en el 97% de los pacientes. Recomendada en pacientes jóvenes que requieran un poco más de fuerza. Entonces, mejora la fuerza y el movimiento cuando la comparamos, por ejemplo, con el Darras. Da soporte al carpo, desaparece el dolor del 97% cuando se indica de manera adecuada en un paciente que tiene compromiso claro de la radioulnar distal. Posibles complicaciones, la no unión, y esto va a depender de que escarifiquemos bien las dos superficies articulares, que hagamos una fijación adecuada, un retardo en la consolidación, la unión ósea o fibrosa y la inestabilidad del muñón proximal cuando no se ha estabilizado pues, de manera adecuada con las diferentes técnicas tendinosas. Hemos aprendido con un profesor de nuestra ciudad, con el doctor Carlos Guerra, una técnica para estabilizar, ¿sí? Que consiste básicamente en hacer perforaciones en ambos extremos y hacer una estabilización con esta sutura, una sutura fuerte, una supersutura puede ser. Este, por ejemplo, es un caso de un paciente con una artrosis radioulnar distal a la que le hacemos esta cirugía. Aquí de pronto logran ver acá las perforaciones, ¿de acuerdo? Las perforaciones a nivel de ambos muñones, y este paciente tiene un buen resultado. Tenemos cerca de unos 19, 20, 22 pacientes, tenemos 22 pacientes con esta técnica y hemos logrado una estabilidad adecuada, estabilidad del muñón proximal y una ausencia del dolor cuando está bien indicada en estos pacientes. Otros tratamientos para la articulación radioulnar distal, la prótesis. Aquí tenemos las diferentes propuestas que existen en el mercado, prótesis parcial o prótesis total. Entonces, prótesis parcial, por ejemplo, para una artrosis radioulnar distal, cuando no hay inestabilidad, cuando no es una cirugía de salvamento para Darras, habría que hacer una cirugía, una prótesis total, y dan buenos resultados según los reportes en un 60-70%. Y una prótesis total ulnar cuando hay inestabilidad dolorosa, cuando hay falla de otras técnicas o cuando hay, por ejemplo, fracturas de una prótesis parcial. Todos conocemos ya las indicaciones y las características de la prótesis total, de la prótesis propuesta por el doctor Shecker. Entonces, básicamente, conclusiones de esto. Etiología variada, pero más degenerativa y postrauma cuando hablamos de artrosis radioulnar distal. Diagnóstico clínico e imagenológico, muy importante tener en cuenta las variantes anatómicas de esta articulación para poder establecer cuáles pueden ser los tratamientos a la hora de hacer osteotomías o de hacer algún tipo de artroplastia de resección. El Darras para ancianos y poca demanda sigue siendo una opción vigente para este tipo de pacientes. Las artroplastias de interposición para estos mismos pacientes, la artrosis Sobeca-Panchi para los pacientes más jóvenes y la prótesis de ulna parcial o la prótesis total, ¿cierto? Opciones que de pronto en nuestro medio, aquí a nivel local, en nuestra ciudad, no tenemos gran experiencia en esto, pero puede ser una opción que concluyen los expertos en este tema. Muchas gracias.
Muy bien, doctor López, muchas gracias por su colaboración, bastante interesante y seguro va a haber también bastantes preguntas ahorita de la audiencia. Entonces, vamos a pasar a una pequeña sesión de preguntas y respuestas finales. Estamos en este momento, vamos a dar unos 10 a 15 minutos para que los asistentes al webinar puedan hacer sus preguntas. Entonces pueden enviarlas por favor a los diferentes chats que tenemos o las pueden enviar aquí también directo a la plataforma de Zoom, o si quieren pueden hacer apertura de su micrófono para que puedan hacer las preguntas. La primera pregunta que tenemos, Dr. Rui, I know you remember Maria Cristina Rodriguez from Barranquilla. So she wants to know, you said that you use a lot of injection for the diagnosis of the distal ulnar pain. So she wants to know if you use ultrasound to guide the injection in order to locate better the medicaments, so you try to get a better diagnosis, and maybe you have some tricks to share for us once you are injection.
I typically don't use ultrasound for most of the injections. I do use ultrasound. The only one I do for the ulnar side of the wrist is a piece of triquetral joint, because sometimes that may be a little difficult to get into. Also the CMC, if it's a previous fracture and or there's arthritis from a CMC fracture dislocation, I have used that before. Otherwise, for a mid-carpal injection, I just use your ulnar mid-carpal portal injection site. And then for a radiocarpal injection, I just inject in the 4-5 arthroscopy portal and DREJ just proximal to that. And the injection is helpful because if I don't know if it's tendon, ligament, or intra-articular, if I inject the ECU, let's say, and they don't have any pain relief, then I know it's probably deep inside the joint, or I know I didn't discuss this, but sometimes patients that have had previous ulnar-sided surgery, their dorsal sensory branch ulnar nerve may be irritated, and that may cause some pain. And so if I inject superficial and that gets better, then I know it's extra-articular. So I feel like it cuts down my potential diagnosis in half. We do have ultrasound, but I typically don't use it because it just takes too much time in my practice. I'm curious if Dr. Adams, if you use ultrasound, because I know you probably do a lot of injections on the ulnar side of the wrist.
Well, I'll take a bit of a different side to it. I think I'm a bit biased against injections as the ultimate diagnosis. I think sometimes just the fact of the needle and they're injecting, they're fearful enough that it sort of changes how they report their problems. So I think injections are a little bit worrisome for patients that tend to have a anxiety component to their problem. But if it's somebody that's very stoic and you are using the injection as confirmatory rather than diagnostic, then I'm much more excited about my injection. So maybe I just got a little more conservative as I got older. But again, I'm more of a confirmatory rather than truly diagnostic. And I'm with you. I'm probably just not as proficient at using ultrasound as I could be. Certainly, I think for me, I would still prefer fluoro over ultrasound for actually some articular injections. I think ultrasound is probably more helpful, at least for me, for, as you already mentioned, making sure you're in the ECU sheath or you're in other soft tissue areas that you might be interested in.
Right. So now I have a question for Dr. Adams. Osteotomy in a patient with a traumatic tear of the triangular fibrocartilage complex.
I'm losing you a little bit, I think. Sorry.
Yeah, she wants to know if you will ever consider doing an osteotomy of the of the ulna, a shortening osteotomy of the ulna in a patient with a traumatic lash injury of the triangular fibrocartilage complex, also with a congenital positive ulnar variance.
Yeah, I think that's a good point. Years ago in my practice, if they were ulnar neutral or even slightly ulnar positive, then I only addressed the Tfcc tear, and I essentially ignored their ulnar positive variants. In the last 10 years, I'm much more likely to perform an ulnar shortening osteotomy at the same time that I'll do a peripheral repair. And I showed those two articles that support that concept, and there are other articles that are similar, more recent than even those. And that's been my finding. Again, I think we all do quite a few activities and have quite a few injuries in our life that should have torn the TFC. And yet we don't see it as prominent as some, for instance, rotator cuff tears, which supposedly are in almost 1/3 of humans. And it's because that the rotator cuff is susceptible to degeneration and tear. I think the TFC is similar. I think there is a large group of patients that are susceptible to TFC degeneration and tears. And if we don't change that environment, then I think they're just prone to re-tear or not to do better. So I think by ulnar shortening osteotomy, whether it be, even if it's a normal variant, if you will, developmental, or if it's an acquired from traumatic, then anybody that has a very thin TFC, either by arthroscopy, MR scan, or direct visualization at the time of surgery, if it's thin and they're slightly ulnar positive, then I'm likely to do an ulnar shortening osteotomy at the same time. On the other hand, if it's a very thick TFC and they're only mildly ulnar positive, let's say an ulnar +1, then I probably would not.
Okay. How do you feel about the DRUJ prostheses? How do you like them? You use them a lot?
I wouldn't say, despite being involved in prosthesis of the distal radial ulnar joint, I'm still quite conservative on their use. I think they're more durable than other arthroplasties, for instance, total wrist or hemiarthroplasty of the radiocarpal joint. I think DRUJ arthroplasty actually does quite well. Early on, I think studies showed higher failure rates because we use them in inappropriate patients, at least in my opinion. I think in highly selected patients, either a partial or total ulnar head can work well. The main entry criteria, the main really important factor is that the joint is stable before you consider the arthroplasty, before you would do an implant. Because when you do the implant, you obviously disrupt the soft tissues to some degree just to get it in there. And so if it's unstable and you disrupt more of the soft tissues, even if you do an adequate repair, I think there's a higher risk of having an unstable joint after the implant. So the main, my indications are DRUJ arthrosis with good alignment of the DRUJ and not excessive ulnar positive variants. That would be my ideal patient. Now, if you use the Aptus prosthesis, then obviously you can expand your indications because it's a much more complex procedure that restores stability. But what I was saying earlier was about the unconstrained prosthesis, either a partial ulnar head or a total ulnar head. It has to meet those criteria.
Ok, thank you very much. Meister, una pregunta, ahí cuando describiste en el sobre Capangi que están usando allá en Medellín una supersutura para estabilizar el segmento proximal del cúbito con la parte artrodesada, ¿no han tenido erosiones o con el tiempo que falle y que se termine soltando esa parte y después genere algún otro tipo de problema adicional? ¿No les ha pasado? Micrófono. Meister, activa el micrófono, por favor.
Sorry. Okay. Que de pronto quede inestable el muñón si se llega a romper la sutura. ¿A eso te refieres?
Sí. O que hayan notado que de pronto genere la misma sutura erosión en el hueso a largo plazo, porque igual son para pacientes.
No. Y les confieso que no hay una explicación biomecánica, ¿cierto? Pero la configuración que utilizamos entre los dos muñones es como un reloj de arena, ¿cierto? Vienen acá y hacen una configuración así porque se cruzan. ¿Sí me entiendes? Se cruzan así y tal vez, no hemos hecho ningún estudio biomecánico, pero tal vez eso permite que haya más compliance, ¿cierto? Para hacer los movimientos de pronosupinación que está haciendo el muñón proximal. ¿Sí? Pero no hemos detectado nada de eso hasta ahora. Y la supersutura no es una supersutura diferente a un etibón 5.0, ¿cierto? De estos que son bastante gruesos, o una supersutura de las que usamos, por ejemplo, para el manguito rotador o para cruzados, ¿cierto?
Ok, listo. Aquí tengo una pregunta de doctor Iriarte que quiere saber qué tan importante, qué tipo de variante presenta la anatomía de la articulación radiocubital distal antes de hacer un procedimiento en una articulación que ya no tiene cartílago.
¿Qué tipo de qué, perdón?
¿Qué tanto consideras tú la articulación radiocubital distal antes de hacer la cirugía cuando la articulación ya no tiene cartílago?
Si no tiene cartílago, ¿cierto? Si el cartílago está totalmente lesionado y lo que voy a hacer es una cirugía, por ejemplo, tipo Bowers o una hemiresección, ¿cierto? O un uso de Capagni, pues no se tiene en consideración. La tengo en consideración cuando voy a hacer una osteotomía de acortamiento ulnar, ¿cierto? Porque en algunos casos, tú, si tienes una artrosis muy leve, que no compromete toda la zona de la cavidad sigmoidea, tú puedes hacer una osteotomía y con eso le cambias la zona de apoyo, ¿cierto? Es similar a lo que hacen, por ejemplo, algunas osteotomías, por ejemplo, cuando hablamos de osteotomía de alineación a nivel de la tibia, por ejemplo, proximal. Cambiamos la zona de apoyo y eso te da un poco más de tiempo sin dolor, pero solamente cuando la artrosis es muy leve, ¿cierto? Si hay un cartílago totalmente dañado, pues no vale la pena tenerlo en cuenta porque no voy a hacer una osteotomía, ¿cierto? Haría un procedimiento tipo sobre Capagni o, dependiendo de la edad, un Tarrasch o una resección, una hemiresección con artroplastia e interposición.
Ok, perfecto. Ok. And I have another question for Dr. Adams. So you use all the time when you do the shortening osteotomy of the ulna, you put the plate on the dorsal side, right? So
Correct.
Would you also recommend that to be used on a patient that is a hardworking laborist who works in construction and everything? Don't they tend to present tendinitis more commonly?
I think if you put the plate on way distally where it's just underneath the ECU, then I think they can get tendinitis. But I think if you notice on yourself right here in your forearm, is the ECU tendon by about this position here, actually right there, is no longer opposed to the ulnar shaft. So I think there is plenty of room for the plate to be dorsal. And I have not found that as a problem in the heavier labors. Now, in the heavy labors, they usually have a stronger forearm, so they have more muscle, and perhaps it doesn't really matter. Maybe they have more padding in this area of the ulna for when they're against tabletops. So in that group, it probably matters less. But in somebody that's thinner or putting their arms on the edge of a table frequently during the day, I find it's very helpful to have it dorsally.
Okay. All right. Okay. Thank you very much, Dr. Ree, Dr. Adams. Thank you for joining us tonight. I think it was a very good webinar. Of course, it's a very large subject. We can do a whole convention of ulnar sciatic wrist pain, but I think we got pretty much a very good idea of the topic. So thank you very much for joining us tonight. We will see you in Barranquilla as well on our convention, on our national convention. So hope to see you there very soon. Thank you very much. Good night. Meiser, muchas gracias por tu participación. Muy buena conferencia también. Estamos muy agradecidos. Muchas gracias a todos por su participación. Como siempre, queremos también dar las gracias a Suplemédicos Diverquín por todo el apoyo logístico que nos da para la realización de estos webinars. Muchas gracias a todos ustedes, muchas gracias por su participación y que tengan una feliz noche. Hasta luego.
Bye bye.
Thank
Good
you.
night.
Thank you. Bye bye.